Hi, I'm Teresa Hall, and I'll be discussing a scoping review regarding termination of resuscitation in children following out of hospital sudden unexpected death. This project was completed under the guidance of Dr. Stacy Drake as part of the Honors Undergraduate Research Program at the UT Health Physics School of Nursing. Though there have been widely accepted guidelines for pre-hospital termination of resuscitation in adults since 2003, there is not a similar algorithm for children, largely due to lack of evidence because arrest in children is rare. We are particularly interested in the experiences related to the unexpected death of children under 5 because the emotions surrounding the death of young children can be especially complicated for both EMS personnel and the child's family. These emotions can impact the decision of EMS personnel to continue resuscitative efforts and transport deceased children to the hospital even when those actions are medically futile and may even pose a risk to the public due to the increased likelihood of motor vehicle accidents when ambulances are operating with lights and sirens. For example, sudden unexpected death in children includes SIDS cases. In these tragic instances, the infant is usually found far too late for resuscitation to have any chance of success. Attempting to resuscitate the child may give the family false hope, and transporting the child to the hospital with full lights and sirens is both a misuse of resources and an unnecessary risk to public safety. The big question we wanted to answer was, how did the decisions regarding termination of resuscitation in the sudden unexpected death of children under 5 made by EMS impact the emotional response of both the family and the first responder involved? We wanted to conduct a scoping review of the current literature in order to identify the reactions of healthcare workers and families to pediatric unexpected death, interventions currently recommended for practice, and literature gaps where further research is needed to provide perspective on the problem. When beginning the scoping review of literature, I first had to decide which databases to use. With the help of librarians from the Texas Medical Center Library, I decided on PubMed and Embase. Next, I identified 4 big categories of search terms that I combined using Boolean search techniques. There were terms that refined the articles to include only studies focusing on children under 5, sudden death, resuscitation, and the pre-hospital setting. This diagram shows that when I screened the abstracts of the resulting 576 non-duplicate search results, I selected 16 papers for full text review. At this stage, articles were selected if they included subjects within our established age ranges, involved pre-hospital care, involved resuscitation after sudden unexpected death, and discussed the emotional responses of families or EMS workers to choices made during the sudden unexpected death of a child under 5. 6 articles were ultimately selected for inclusion in the study. One of those sources describes the scope of the problem, 2 outline guidelines for EMS personnel, 2 relate to pediatric death within the emergency department setting, and 1 is a legal case study. This 2005 study analyzed records for 113 infant deaths in 2 urban California EMS systems. Though the method of transport was only documented in 44% of the cases included in the study, all 50 of those infants were transported to the hospital with lights and sirens. This led the authors to suspect that most, if not all, of the children were transported with lights and sirens, including the 28% of patients who showed obvious signs of death, including rigor mortis, lividity, or decomposition when emergency personnel arrived. The authors of this study suggest that when responding to pediatric events, the focus should be shifted to supporting the infant's family rather than attempting resuscitation and transporting children that are unlikely to survive. The 2010 Basic and Advanced Life Support Guidelines from the American Heart Association indicate that there's not sufficient evidence to establish termination of resuscitation protocols for children. Instead, the advice they provide focuses on allowing the family to be present for resuscitation in order to prevent feelings of uselessness and to help them adjust to the child's death. Additionally, the guidelines note that 39 to 66% of EMS personnel report sometimes feeling threatened by family members during resuscitation. Feeling unsafe may contribute to the hesitance to terminate resuscitation for some EMS personnel, indicating that future studies should investigate how their decisions are impacted. The National Association of EMS Physicians outlined protocols for pre-hospital personnel after the death of a child or infant. These protocols suggest discussing the resuscitation process, the transport decision, and further actions that will be taken by medical staff with the parents. EMS personnel should remain supportive and professional regardless of parental reactions, allow the parents to say goodbye, and be responsive to parental requests with regard to unique cultural needs. The authors also recommend obtaining a recent patient history, assessing the environment, and documenting the event thoroughly. Unfortunately, these suggested protocols do not specifically indicate when resuscitation should be terminated, other than in the case of obvious signs of death. In addition, the protocols provide only vague suggestions for communicating with parents in the aftermath of a child's death. More in-depth protocols and training recommendations are needed for EMS personnel to be truly prepared for termination of resuscitation and therapeutic communication with the family after a pediatric arrest. There were a few articles I identified as useful, though they were related to the emergency department setting and did not involve EMS. Through one-on-one interviews of 8 healthcare workers, Lindsay and Helliker identified various sub-themes including teamwork, the difficulty of watching children die, thinking about their own children, lack of education on the subject of pediatric death, vicarious trauma, coping strategies, and what-if scenarios where things might have gone differently. Participants also reported feeling trapped and angry. Unfortunately, this study failed to involve out-of-hospital personnel and did not specifically address the decision to terminate resuscitation. Suggestions for nurses and physicians interacting with the family in the wake of a child's death in the emergency department were provided by Brown and Bocock in a review of recent research on the topic of pediatric resuscitation. One study, referenced by Brown and Bocock, analyzed survey responses from 37 parents of children who died in the emergency department. The parents surveyed thought that the following interventions were important: keep the family updated, ensure that the family has a chance to view the body, provide mementos, act warm and sympathetic, answer all questions, provide follow-up for the family. Respondents also believe that the news of the child's death should be given by the attending physician and in private. Another source indicated that 40% of physicians admit to extending resuscitation beyond all hope due to reluctance to talk to the family and/or feelings of guilt. Notably, interactions between parents and EMS in the pre-hospital setting were not explored in this article. In a 1993 SIDS case where the family performed bystander CPR, the EMS personnel later decided not to continue. The family unsuccessfully sued the ambulance company because they believed continuing CPR may have saved the child. Though the family lost this case, therefore establishing legal precedent for termination of resuscitation in the field, lawsuits like this may leave emergency personnel hesitant to terminate resuscitation for fear of legal consequences. The literature discussed has several implications for practice. Resuscitation should not be attempted in children who show obvious signs of death such as lividity, decomposition, or rigor mortis. In addition, these children should not be transported with lights and sirens. If resuscitation is attempted, the family should be allowed to stay while resuscitation is performed unless the family is impeding care. We need to train medical staff to communicate with bereaved parents and particularly to explain why resuscitative efforts are being discontinued. We also need to make sure healthcare workers always feel like they have someone to reach out to for counseling or stress debriefings after difficult events like the death of a child in their care. It is important that we adopt policies to ensure that the family has time to view the body, that follow-up is provided to parents who want it, and that all of the family's questions are answered. Ultimately, we need widely accepted guidelines for pediatric termination of resuscitation. Termination of resuscitation in children will never be a simple decision, but having clear algorithms would doubtless remove some of the weight of the decision from the shoulders of emergency personnel, reducing the potential for feelings of indecision and guilt. Because the emotion of families and first responders are important to adherence in any proposed termination of resuscitation guidelines, future studies should be performed to help us understand these situations and eventually develop appropriate interventions for both families and emergency medical personnel following these events. I found very little literature directly addressing the emotions surrounding the termination of resuscitation in children. While I did locate some guidelines for how to treat parents, there were no studies including first-hand accounts of parents or first responders that specifically addressed the decisions to terminate resuscitation or how they felt afterward. More research should be done regarding the pre-hospital setting in general. Very few articles identified, even in the full dataset, investigated the pre-hospital setting. Qualitative research on how parents feel and why they would suggest certain interventions should be conducted. We need to know how actions of healthcare personnel during pediatric death impact the family and how current procedures could be improved. Some limitations of the study were that I only used 2 databases and that the search terms were not fully optimized. Removing the age restriction on subjects may have led to locating more applicable studies regarding the experiences of parents and emergency personnel. The strengths of the study were that I evaluated over 500 sources for their applicability, leading to the identification of several research gaps. In conclusion, this study effectively identified several literature gaps surrounding pediatric resuscitation. These literature gaps constitute important areas for future study that may help us to better understand these situations and eventually develop further interventions for both families and first responders following these events. The following are the references used in the course of this study. Any questions can be directed to myself or Dr. Drake at the following email addresses. Thank you for your time, and I hope this presentation has brought this important problem to your attention.